afternoon, ladies and gentlemen, and welcome to today's Facebook live from Milton Keynes, live from... Good afternoon, ladies and gentlemen, and welcome to today's Facebook live from Milton Keynes, live from Wound Care Today, in partnership with and Wound Care Today. We are well aware how busy you guys are, so thank you for your time. It means a great deal to me. In partnership with MICROWORLD and Wound Care Today. We are well aware how busy Chrissy and to the team who you can't see behind the camera. Today's event, Chrissy and to the team who you can't see behind the camera. Today's event is called Wound Infection, a new animated way to learn, and our fantastic speaker is here with me now. How are you, Chrissy?
I'm doing very well, thank you, Ed.
How's the event?
I'm loving it. The reception's been good.
How's the event?
I'm loving it. The reception's been amazing.
Good. Thank you for coming.
Thank you.
Thank you for your support. As you can see, ladies and gentlemen, we are live from our national conference, so if we have any technology problems, please bear with us, and I promise you we'll get them sorted. From our national conference, so if we have any technology problems, please bear with us, and I promise you we'll get them sorted as soon as possible. The link for the certificate of attendance will be made available towards the end of tonight's event. This counts towards your revalidation, so make sure you download that link. As for the certificate of attendance will be made available towards the end of tonight's event. This counts towards your revalidation, so make sure you download that link. As Chrissy will probably agree, the more engaged you are, the better it will be for the event and for her. So the more engaged you are, the better it will be for the event and for her. So make comments, ask questions, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. This is the launch of our third MICROWORLD module. So for those who haven't, and we'll endeavour to answer as many of them as possible towards the end of tonight's event. This is the launch of our third MICROWORLD module. So for those who haven't gone, go to mymicroworld.online. We have wound healing, we have EXUDATE management, and the wound infection module is launching at noon tomorrow. So if you haven't seen it, go there now, and if you want something new, go there tomorrow at noon. Genuinely, it is something we're incredibly proud of. We're trying to challenge education in this marketplace, and we massively relish your feedback. Tell us your thoughts, tell us your views. We'll take them on board and get it right for number 4. Before we start, a massive thank you to our partners, not just for tonight's event, but for the MICROWORLD platform throughout the world, who are Mernlicher. It takes real bravery and courage to support something that's new, that's different, and you have that in spades. So a massive thank you to Mernlicher for your support. Without you, this event simply could not happen. So thank you very much. So without further ado, it gives me great pleasure to introduce you to tonight's speaker. Over to you, Chrissy.
Thank you, Ed. So, welcome to the new MICROWORLD module. It's a module on wound infection, and my name is Kristina Stiles. I'm a burns and plastic surgery nurse specialist, and I will be your guide today. At the end of this session, you should be able to understand all of the components that make up MICROWORLD. You should be able to understand how MICROWORLD can offer a new animated way to learn and how it can enhance your learning experience. We'll also be looking what wound infection is, stages of wound infection, how we identify wound infection, and the principles of treatment. You should also be able to explore MICROWORLD and register. Of course, we all learn in very different ways, and it's important that all of our teaching and educational materials embrace the different learning styles. MICROWORLD provides just such a non-traditional approach to learning. MICROWORLD can connect us as colleagues all across the world. Completing the module will count towards your revalidation. It will open other learning areas of the site as well. Complex content will be delivered through fun, engaging interactive animations, videos, games, and also illustrations. Check it out. You might remember that in class 1, we learned about wound healing, And in Class 2, we covered essentials of wound exudate. The very first module focused upon wound healing stages, which are the fundamentals to understanding wound assessment and management. And the second module focused on the role of wound exudate. Let's remind ourselves of the MICROWORLD characters we've already met in previous modules. We've got gluco, who is the body's primary source of energy. We've got Mr. Rex. It's the fluid produced by the wound to maintain a consistent moisture level to bathe and cleanse the wound. Mac the cleaner detects, engulfs, and destroys bacteria and debris, cleaning up the wound. Newt are the white blood cells which trigger tissue injury inflammation and destroy bacteria and debris. MC are the larger white blood cells that transform into macrophages to clean up the wound. And then there's scarlet, red blood cells. They're the main cells of the blood which pick up the oxygen from the lungs and deliver it around your body. Clotsworth are the small blood cell fragments which cause the blood to clot. There's the controller, initially released by platelets on injury, but also by macrophages and other cells to stimulate wound healing. Then we have the pro-twins. Pro-twins, protease enzyme. That's the first enzyme that breaks down proteins in damaged wound tissue. And then we've got the protease inhibitor, which ensures that proteases only break down the damaged proteins. Yellow and blue provide energy and resources needed for healthy wound healing. And lastly, fibroblast and myofibroblast are the long, thin cells which pull the edges of the wound together to speed up the wound healing progress. So here are the new characters for wound infection. We've got E. coli, we've got Pseudomonas, and Staphylococcus. Here's a short snippet from the infection module.
The wound fight is on. A fight our team normally could win in their sleep, but something is different. This isn't just any wound, this wound is infected. As common as wound infection is, it doesn't make the battle any easier, and it's one that needs to be won to get the healing process back on track. And as you can see, it's got our team with their backs against the wall. And if Mr. X is this panicked, I'm not sure they'll find a way out of this jam. Wound healing isn't always under attack like this though. Our team has seen better times. Remember the phases of healing.
So, this class will take you through what wound infection is, the stages of wound infection, how to identify wound infection, and how to treat it. Wound infection is the invasion of the wound with microorganisms such as bacteria, fungi, and yeast. Most wound infection is caused by one or more species of bacteria. And the effect that bacteria have on the wound is often influenced by species of bacteria, their virulence, and the ability of the patient's immune system to combat them. The most common bacteria that you can find in chronic wounds will be Staphylococcus aureus, a high toxicity bacteria, Pseudomonas aeruginosa, that can cause biofilm to form. Together, these two are more virulent than alone. And Escherichia coli, one of the leading causes of wound infection. Wounds can become infected in several ways: through direct contact, through transfer of microorganisms from the hands of a healthcare professional, another person or carer, or equipment that isn't sterilized or clean. Then there's airborne dispersal, through microorganisms that are already in the air that can make contact with the wound, or through self-contamination, through bacteria from another part of the body, like the skin that's migrating to the wound. Of course, the diagnosis of wound infection is a challenging aspect of our management. The wound infection continuum was developed to make it easier to understand the stages involved. This is the fantastic slide that demonstrates the wound infection continuum that consists of 5 specific and identifiable stages, with addition of increasing biofilm load. In the contamination stage, microbes contaminate the wound, but don't cause a response in the host. And the host defenses usually destroy them quite quickly. In the colonization stage, the microbes increase in numbers, but still don't delay wound healing. In these 2 stages, it's important to be vigilant, but intervention isn't usually required until the next 3 stages of the wound infection continuum. The local infection stage is where the microbes will increase in greater numbers and move deeper into the wound. In the spreading infection stage, the affected area begins to spread from the wound and invades surrounding tissue. And finally, the systemic infection stage is where not only the wound and surrounding area, but the whole body is affected, especially in the vascular and lymphatic systems, showing signs of sepsis and organ failure. In chronic wounds, it is important to recognize the difference between the early stages of contamination and colonization compared to proliferation of microorganisms that result in local, spreading, or systemic wound infection. Generally, colonized chronic wounds will heal uneventfully without any delay to wound healing. Don't undertake microbiological analysis such as wound swabs in the absence of an appropriate indication. Let's have a look at the risk factors for wound infection. The systemic risk factors might include comorbidities, so your patient with circulatory metabolic disorders such as diabetes, renal disease, or rheumatoid arthritis. Patients on medications such as immunosuppressants, poor nutrition, alcohol abuse and smoking, and often the extremes of age too. In chronic wounds, the risk of infection is also increased by the presence of devitalized tissue or debris, prolonged duration of the wound. Obviously, the longer it is around, the more likely it is to become infected. Large and deep wounds, the more surface area there is for microorganisms to enter. Sometimes anatomical site itself for wounds near the anal area, and poor standards of wound hygiene. The clinical signs of wound infection can be divided into covert, subtle signs, or overt, the classic signs. Covert signs may include overgranulation tissue or excessive vascular tissue, friable, bleeding, bright red granulation tissue, epithelial bridging or pockets in the granulation tissue, further wound breakdown and increase in size, delayed wound healing, and increasing malodor. The overt signs may include erythema and redness, warmth and swelling, purulent discharge or sudden increase in volume of exudate, and new or increasing pain. In acute wounds, such as surgical trauma or burn wounds, there may also be further extension of the erythema or redness, inflammation of the lymph vessels identified by red skin streaks. There's crepitus, which is a crackling feeling in the local tissue, and wound breakdown or dehiscence. And for chronic wounds, such as leg ulcers or pressure ulcers, there also may be further signs such as wound breakdown, more erythema, redness extending beyond the wound edges, crepitus, warmth, induration, and discoloration spreading into peri-wound area, inflammation of the lymph vessels, and general deterioration in patient's condition too. It's important that we know and recognize the signs and symptoms of spreading infection, as this will require prompt action. Signs that may include pyrexia, tachycardia, tachypnea, and lethargy and malaise. Wound infection continuum highlights the potential development of a wound biofilm. Wound biofilm can impair healing and predispose the wound to an infection. Holistic wound assessment, combining clinical judgment with clinical observation and the ability to risk assess each patient individually, will ensure early identification of a wound infection. Wound biofilm is a community of microbes that attach themselves to a surface and cover themselves with a substance known as extracellular polymeric substance, EPS. This EPS acts as a protective barrier to the host immune response and to antimicrobial activity too. Biofilm can also be difficult to detect without the aid of specialist techniques, but there are clinical signs that we can all be aware of. The indirect clinical signs of wound biofilm may include increased volume of exudate, poor quality granulation tissue, one that's friable, smooth and pale, as opposed to granular and bright red. Signs of local infection may be erythema, redness, heat, swelling, pain and odour. History of antibiotic failure, such as persistent or recurring infection. Culture negative results. Wound biofilm microbes are almost impossible to culture. No signs of wound healing, even though etiology and comorbidities have been treated, such as compression therapy for a venous leg ulcer. Although biofilm cannot be seen with the naked eye, visual clues of a wound biofilm may include shiny, translucent substance on the surface of the wound, opaque, loosely attached patches in some parts of the wound, formation of viscous, slimy or gel-like substance. Is difficult to distinguish it from slough, but it's usually much easier to remove and it does reform quite quickly. So early identification of a wound infection will always begin with a holistic wound assessment that must combine clinical judgment with clinical observation based on each individual patient. Assessment should include general health information, the wound history and baseline data, your wound assessment parameters such as depth and tissue type, wound symptoms such as exudate volume, pain, odour, looking for signs of local or systemic infection, and specialist information such as specialist referral or diagnostic tests. Diagnosis itself of a wound infection is dependent on clinical signs and symptoms described. If it's clear that the wound is infected, now it's time to get confirmation and identify the causative organisms and any sensitivity to antibiotics. This can involve microbiological investigations, blood tests, and possibly imaging. If a wound swab is clinically appropriate, take a specimen at and below the wound surface using the Levine technique. It means you need to cleanse and debride the wound, if necessary, before the swab is taken. Don't use antimicrobials. Remember, despite being the most widely used technique for microbial monitoring, wound swabs may not distinguish between colonization and wound infection. Inappropriate wound swabbing can lead to general misuse of antimicrobial agents and contribute to increase in antimicrobial resistance. The principles of treatment are twofold. You need to either optimize the host response and thereafter manage the wound. It's important to address the underlying comorbidities to ensure maximum healing potential. For example, optimize glycemic control in people with diabetes, reduce edema, reduce pressure in people with or at risk of pressure ulcers, ensure adequate nutritional status, and provide psychological support to patients and their carers or family. Local wound infection quite often needs only topical treatment. For spreading or systemic infection, you have systemic treatment alongside the topical treatment. Wound debridement, will require physical removal of devitalized tissue, debris, and disruption of biofilm as a result. There are two principal treatment options: antimicrobial agents that either kill or inhibit microorganisms, such as iodine, silver PHMB, and honey, or dressings that adsorb, absorb and retain organisms, such as bacterial binding dressings, absorbent cellulose fibers, and superabsorbent polymer dressings. Diagnosis and treatment of wound infection takes a multidisciplinary approach. Regular assessment is very important in the management of wound infection to evaluate the effectiveness of treatment, in particular looking at whether the signs and symptoms of wound infection have already resolved. A step-up and step-down approach is advocated to ensure antimicrobial dressings are only used when required. Treatment of wound infection needs to be assessed over a 2 to 4 week period, and if one type of antimicrobial has not been effective, another antimicrobial from another group can be tried. Wound infection poses a significant challenge to healthcare professionals. It has a detrimental impact on the quality of life of patients. Wound biofilm can delay wound healing and increase the risk of wound infection. So early identification of wound infection begins with a holistic assessment. Treatments should be regularly reviewed and adapted according to assessment findings. So by the end of completing this module, you should be able to access new content, view your activity, and visually track, monitor, and analyze your performance, all from your personalized MICROWORLD dashboard. You can repeat and recap information you've learned. You can undertake a test to assess your learning, and you can monitor progress on your own MICROWORLD dashboard. And finally, explore MICROWORLD for free. You can sign up online and start exploring, and you can register at MICROWORLD, mymicroworld.online, to undertake the modules. Thank you.
That was absolutely awesome. I'm going to high five you. I'm well aware you may have been slightly nervous, as was I. Couldn't be more professional. Some of the comments that are coming through, incredibly kind. So if you get a chance, do watch us again, because there's some kind things said, some great engagement. So thank you to everyone out there. I think we should crack on with some questions, if that's okay.
Let's go.
So there's quite a few have come through. So question one, thank you for this. I work in a nursing home. What is the one takeaway I should remember from your presentation?
To pick just one, so I would go for the wound infection continuum that actually gives you the incremental stages of how bacterial load develops in the wound and how the biofilm grows. But ultimately, it is all down to your clinical judgment, your observational skills, and getting to know your patient. Those are the three things rather than the one.
Well, I love
ta-da.
the three. I'll go with the three. So question two, what do you make of the MICROWORLD platform?
So I've had a go,
Yeah.
and it is very visual, it is rather interactive, and actually is quite challenging. It makes for a really good reminder for the basics and more extended knowledge as well. So I personally really engage with it. I love the animations.
Brilliant. And that's really, what we tried to do with it. We've actually got the visionary behind it in our audience tonight, and the vision was always to try and make something more accessible, something that we could globalize. I think with the animation characters, you can really bring them alive in whatever language. But also, we've had specialists say amazing things. We know they're using it for their own training. We've had the everyday healthcare practitioner love it, but also patients and their carers. Definitely. And the idea, the vision behind this was we wanted something that was accessible to everyone, that we could cut up into short bite-sized pieces as well, use on social media, just do something a bit more modern. So, I'm incredibly proud of it. So, guys, we'd love you to get involved. Question three, I should plow on, I'm going to get into trouble. Are there any wounds that are more likely to be infected?
So we talked about the chronic wounds that have the biggest bioburden. So you've got formation of biofilm, they stay around and open for much longer duration. So wounds like chronic leg ulcers, wounds like your pressure damage wounds are probably the most likely to sustain infection.
Thank you. Next question. This is from Ellie, so thank you, Ellie. Can you revisit the wound infection continuum, please? I've seen it before, but it didn't include biofilms.
I do actually really like the wound infection continuum. It's brilliant, and the addition of biofilm starts to make much more sense. So you start off with the 2 stages that you need to monitor first, and then you enhance and advance into much more localized spreading and systemic infection. The biofilm, as we explained, and if you want to go back and just revisit it in the module, you have bacteria, microbes that form a protective coat around them that become quite resistant to our interventions. And the longer the wound stays open, the more signs and symptoms you see in the wound, the more likely you are to form biofilm and it'll be resistant to your interventions. So double check back on the module. It's absolutely fantastic, and the wound infection continuum actually is a great visual demonstration of what's happening at the wound end.
Brilliant, thank you. So our last question, and then we're done. I see a lot of wounds that are slow to heal. How do I know if infection is contributing to this?
Yes, same here. So we get a lot of chronic wounds and burns and plastic surgery as well. So I appreciate the burden. Sometimes it is that we're not picking up some of the signs and symptoms. So again, just revisit your basic assessment of the wound, what you're seeing, what is the patient feeling, and possibly some of the patient's factors also might be contributing to that as well. You might have patients who are on immunosuppressant medication, for example, who actually would not develop the infection response, so that inflammatory response you would normally see in other patients. So you just watch out for that. What medication is patient on? Sometimes having steroids involved as well might compromise wound healing for you. And patient factors like nutrition. At the very basic level, the wound needs energy to heal. So if you don't have that, it might not be infection. It actually might be the patient considerations that you need to bear in mind.
Chris, I've got 2 more questions that have just come
Yeah,
through.
go on.
Do you mind?
No, that's fine.
What timing should you give before swabbing a wound?
So we always revisit the fact that if you perceive the factors that the wound actually requires swabbing, so you're concerned, which means that you've observed signs and symptoms, your patient's reported signs and symptoms that makes you concerned that the wound may be infected. I wouldn't swab if it doesn't need it. Just, let's see what's growing in it, because you're more likely to test for colonization. So actually swab if concerned, wait for that test to come back, wait for your microbiology to tell you the bug is this and it's sensitive to particular antimicrobials, and then treat. It's the only way that we're going to try to at least maintain and dampen down the antimicrobial resistance that we're really building up amongst our patient population.
Brilliant, thank you. I think this is the last question, but they're all coming through on the iPad in front of me. So this is from Craig Richards. Thank you, Craig. Wound care is a fundamental aspect of nursing for those within our care. While delivering this care for those living with dementia, do you have any advice on adherence to wound care regimes?
So I know as nurses we quite often make care plans and wound care plans for our patients, but I personally feel that the wound care plan is only good enough at the point of assessment. At the time when you've made that plan, you're looking at that wound, because potentially by next time you go to do a dressing change, the wound has changed and looks completely different. So it's good for consistency, and we certainly say with consideration to antimicrobial dressings, you give it a go. You give it a go for a couple of weeks, 2 to 4 week window, and if that's not working, then you swap. So for those moments, the wound care plan are useful, but I would still every time reassess my patient back to the basics: wound, patient, what I see, what patient feels. Really important factors. You've got all of the information at your fingertips.
Brilliant, thank you. So we're now getting questions apparently from the ballroom. So I promise you that glass of wine is imminent. So this is from Sarah. Thank you, Sarah. When is the right time to try maggot treatment?
I love maggots. I love maggots. So, maggots are quite often used for your necrotic tissue in the wound, and actually they're fantastic at managing the bioburden in the wound as well. They're your best surgeons, they're the cleanest, the more precise surgeon than the surgeons we might be used to working with. So anytime you perceive, actually, I'm not able to surgically debride this wound, or I've tried topical treatments, I've tried dressings, materials that actually are not able to manage this. And if you are concerned that the biofilm is building up in the wound, if it's been a little bit more of a long-term wound, maggots are always a great idea. It's persuading the patient, educating the patient, and actually half the time when you've explained to them what it's for, they're game for it. And the outcomes of larval therapy are amazing. I love them.
Brilliant. Look, we promised our audience half an hour. We've given them half an hour.
Good.
We know how busy you are, so thank you for joining us. So that concludes tonight's session. The link for your certificate of attendance is available now to download, so please do. As I said, that goes towards your revalidation portfolio. Go to mymicroworld.online. We're incredibly proud of it. There are 3 modules up as of noon tomorrow, so wound healing, wound EXUDATE now, noon tomorrow, launch of the infection management one, so get involved. Just some thank yous to you. Thank you so much for today. Much appreciated. I'm well aware how much work you put into this. It was outstanding. So thank you for joining us. To my amazing team at Wound Care Today and the team at Mold Digital, again, ludicrous amount of pain and emotion has gone into the last few days, so a massive thank you from me. To the team at Mölnlycke, as I said, without your support, without your trust, this isn't happening. So thank you from me and everyone here at Wound Care Today and MICROWORLD. And last but not least, to you guys out there, you continue to inspire and humble me and my team. What you do is truly incredible, and I promise you we'll continue to support you in every way we can. Stay safe, stay strong, and we look forward to seeing you very soon. Take care and have a lovely evening.
Bye.